Hello, I wanted to just provide you some quick information on general surgery. So when you are at your clinicals this week, hopefully observing one of these general surgeries, you have a little bit of information and a little more in-depth knowledge on what is going on for some of these common procedures that we perform. First, what is general surgery? You can think of general surgery as the specialty that focuses on the abdominal organs and the issues. So that includes all of the alimentary tract, so the mouth, esophagus, stomach, intestines, basically anything in the abdomen and its contents. General surgeons also frequently do surgeries on breast, like mastectomies or lumpectomies, any sort of skin issues, and even soft tissue. They will also deal with surgeries of the endocrine system, so thyroids, parathyroids, and even the adrenal glands. So first, on the far left here, we have our Stryker camera tower, and this is used for laparoscopic surgeries to provide visualization for the surgeon of what's happening inside the abdomen. It is also used in other specialties, orthopedics for knee and shoulder scopes. It's used in robotic procedures, but in general surgery, it's used for laparoscopic surgery. So as you'll notice, there are various boxes inside this tower, and they all kind of have a different function. So starting at the top, that first large box with the small picture in it, that is used for camera capture. So the surgeons can take pictures of the procedure for use in the patient's medical record. So if they need to show the patient maybe something that's going on, or they need to document something for medical purposes, they can take pictures for the patient's medical record. That next box below it is the insufflator box. And so basically this will hook to a tube on the field and it will fill the patient's abdomen with CO2. And this is done to give the surgeon a better field of vision. It, creates that space in the abdomen full of gas so that the surgeons can maneuver their instruments around a little better, and it's safer for the patient when they have more space to work. The box right below it is the camera. So this is actually where the camera would connect in. And then that box at the bottom is where the light cord would go in. Surgeons will need a little extra light to see inside of a dark abdomen. And then at the very bottom is a printer. So if the surgeon needed to print the pictures, to show them to the family, or even to have them scanned into the patient's medical record, they would print out from the bottom. The next piece of equipment in the middle there is the NeoProbe, and this is utilized in sentinel lymph node biopsies to detect involvement of the lymphatic system in breast cancers. So prior to the surgery, patients are injected, and the NeoProbe can locate that radioactive tissue. This can help determine if cancer has spread to more lymph nodes in the patient. So it's a really useful detection tool for those sentinel lymph node biopsies. The equipment on the far right is a variety of endostaplers that we use, and we use different brands, different types. These staplers pictured here are all one brand called Ethicon, but all these staplers, they have a lot of different functions. They can be laparoscopic, they can be used for open procedures, but basically staplers are used for one of three reasons. Either removing part of an organ, so in a colon resection, they can staple part of the colon off. They can cut through and seal organs and tissues, so if they're transecting across an organ or a tissue. Or they can create connections between structures, which is known as an anastomosis. So if there's a colon resection and they take up a part of a diseased colon and then put the two ends back together, that's an anastomosis. They've just removed the diseased portion and reconnected the colon. They use a stapler for that. Use a stapler for all sorts of things in general surgery, and I am sure that you will see these while you are here at North Kansas City Hospital. So positioning for general surgery really does vary widely depending on the procedure. Most often, patients are supine for a lot of the abdominal surgeries, for a lot of the breast surgeries. They can also be in a Trendelenburg or a reverse Trendelenburg. This position will give the surgeon better visibility of some of the organs. For laparoscopic gallbladders or appendectomies, often the patient will be moved so that they have better visualization of the appendix or the gallbladder, basically just using gravity to get a better view. Patients can be lateral if we're doing any sort of skin issues, occasionally breast with breast reconstruction. Depending on how they're doing the reconstruction, the patient could be lateral. Patients can also be prone. General surgeons, like we said, might work on like a pilonidal cyst, or could even work, on skin masses or any sort of like lipoma or anything of the back. And then patients can also be in lithotomy, depending on where the surgeon's working. And we will talk much more about positioning later, but I just wanted to let you know there's no real great way for positioning in general surgery. It kind of is just a little bit of everything. Surgical skin antisepsis is also very important for all procedures. In general surgery, like I said, it's very dependent on the surgical site. The important things to remember about general surgery skin preps is if we're doing any sort of abdominal prep, you always want to prep from the nipples to the pubis. This is just a standard for all abdominal procedures, even if it's laparoscopic. You never know if you might have to go open, and it's always better to prep wider than you think you might need, just in case you need that extra prep during the procedure. You should also pay careful attention to dirty areas. So if the patient has a colostomy, you will always prep that last. And if the surgery is up near the breast, you would always want to prep the axillary area last. Or if the incision is a little bit lower, you would want to prep the groin last. So the dirty area is always last for these procedures. Common procedures that you will hopefully see that we perform the most of in general surgery is a cholecystectomy, so removal of a gallbladder. We most often do those laparoscopic. Hernia repairs, which can be done open or laparoscopic. Exploratory laparotomies, and colon resections, also laparoscopic or open. So cholecystectomy we'll talk a little bit about. So this is the gallbladder removal. So your gallbladder is a small organ underneath your liver which helps aid in digestion. And you can see that little picture over there. That is pretty much exactly what it looks like. Removal of the gallbladder can be done laparoscopic, open, or robotic. Most often here at North Kansas City Hospital, we are performing them laparoscopically. Indications for removal of your gallbladder would be acute or chronic inflammation, which is cholecystitis, or if a patient has a lot of gallstones. So if we are performing a laparoscopic cholecystectomy, the patient will be brought into the room, prepped, draped, and we'll do a timeout. And then when the surgeon is ready to start, they will first make an incision right by your belly button. And then they put in a trocar, which is just a sharp, hollow tube that they can pass their instruments through. And then they they call it a pneumoperitoneum, which is, like I said before, injecting that CO2 into the abdomen to create more space for them to work. They then insert the remainder of their trocars. They usually do either 2 or 3 more, depending on the surgeon preference, depending on the procedure. They will visualize all those trocars going in to make sure they don't cause any damage to the patient's colon, liver, or other abdominal organs. They'll then seek out the cystic artery, clip it, cut it. They will then clip and cut the cystic duct. Then they will begin to dissect out the gallbladder. So at this point in the procedure, you will see the gallbladder and they will start to kind of burn it off the back of the liver, cauterizing it as they go. The surgeon will then inspect the abdomen for hemostasis, make sure there's no extra bleeding. They will irrigate the abdomen, remove all the excess fluid, and then they will pull the gallbladder out through your belly button port, basically. They most often put the gallbladder into a little specimen bag, and they'll pull the bag out. After that, they will decompress the peritoneal cavity, trying to remove as much of that CO2 as they can. The CO2 can be uncomfortable for the patient. Sometimes patients after laparoscopic surgeries will wake up with a sore shoulder, so that does radiate. So removing all that gas is super beneficial for the patient's recovery. After that, they will close all the port sites and apply dressings, which is usually just a little bit of skin glue. For this procedure, the surgeon will usually stand on the left side of the patient, and the patient will be placed in reverse Trendelenburg, often with their right side up a little bit, and that just provides better visualization of the gallbladder. Because if you think about it, that gallbladder is over there on the right side, so if they put their right side up and flip them a little bit on their head, all the abdominal contents are kind of shifting towards your head, and if your gallbladder is on the underside of your liver, it gives a much better view for the surgeon. After the patient is finished with their gallbladder removal, they can be discharged home the same day, sometimes even the next day. One complication that patients have could be diarrhea, but that will often resolve over time. Like we said, the gallbladder aids in the digestive process, so occasionally when it's removed, your body does have to adjust to that. Most patients can return to normal activities in 2 to 4 weeks. If they have an open gallbladder removal, it will take them a little bit longer. Some complications from a laparoscopic gallbladder removal would include visceral or vascular injury from the trocar placement. Like I said, the surgeons have to be very careful when they're placing those trocars at the beginning of the procedure. They can also have those carbon dioxide complications, respiratory acidosis, a change in blood pressure, bradycardia, gas embolus, and then just simply pain from having so much gas in there. That's why it's very important for the surgeons to remove it at the end of the case. They can also have bile leakage or bile duct injury, infection, and bleeding. The next surgery we're going to talk about is a hernia repair. So hernias are abnormal protrusions through an area of weak muscle. There are many different types of hernias, and if you look at this little picture over here on the right, it kind of shows a bunch of different areas for where hernias can occur. So we have inguinal hernias, femoral hernias, umbilical hernias, and incisional hernias. They can be reducible or non-reducible. So sometimes the patient will come in with a hernia and the surgeon can, push it back in, or the patient's been pushing it back in for a while, but sometimes they cannot do that anymore. We can perform hernia repairs open, laparoscopic, or robotic, and we do, I think, an equal assortment of all those here at North Kansas City Hospital. So indications for hernia repair would be pain from the hernia, any hindrance of daily activities, or if the intestines become twisted in the hernia, or the hernia becomes incarcerated. So incarcerated is just part of the intestine or the abdominal tissue gets trapped in the little hernia sac, and that can be very dangerous for the patient. It can cause complications, and it can make the patient really sick. So if a hernia becomes incarcerated, then it kind of becomes a very urgent case that we have to take care of. The procedure for hernia repairs is dependent on the hernia repair. However, most are kind of follow the same flow of they make the incision, they dissect through your tissue of your abdomen until they find the hernia. They reduce the hernia. The hernia sac is removed if present. Occasionally they would place mesh in, and the mesh just sort of provides a layer so that the hernia doesn't recur, and then the incision is closed. These are most often done with just skin glue on the skin, and the patient recovers usually pretty quickly. They can go home the same day or the next day. Full recovery can be up to 6 weeks, but they can often return to work in 2 to 3 weeks. They just have to be careful to not lift more than 10 pounds for 6 weeks because you don't want the hernia to reoccur. And also having a high fiber diet and increasing their fluid intake is recommended. And this helps to prevent straining when having bowel movements, which can also cause your hernia to recur. Complications from hernia repairs include hemorrhage, infection, chronic pain, damage to blood vessels or organs, swelling, and hematomas. So our next procedure we want to talk about is an exploratory laparotomy. And so this is when there is a midline incision which exposes the entire abdominal contents. This procedure is most often utilized to diagnose abdominal issues that can, not be explained or cannot be found until they kind of open you up and take a look. If you can see in this first picture, that is kind of where the incision line would be. They usually make a nice little round curve around your belly button to preserve that. And then on the far right, you can see what it kind of looks like once you get your abdomen open. Liver up top there on the left. So other procedures are often performed. So if a surgeon opens you up for an exploratory laparotomy, they are usually looking for a problem, trying to find something wrong. So they'll inspect all of your abdominal contents, and when they find the issue, they'll usually correct it. So if they open up your abdomen and part of your colon looks like you have, a perforation or you have a blockage, then they might go on to perform a colon resection. So the additional procedures will depend on what they find when they open you up. So indications for an exploratory laparotomy would be abdominal pain or bleeding, bowel perforations, any anastomotic leaks. So kind of like I mentioned earlier, if they've attached part of your colon back together, they check it really well to make sure that there's no leakage, but occasionally, anything can happen, and so there could be a leak. Colon resections or any sort of colon surgery, and then any sort of trauma. If a patient has a penetrating trauma, like a stab wound or a gunshot to their abdomen, they'll probably go ahead and perform an XLAP, opening up, check for any damage. So the procedure is a midline incision created from the bottom of the sternum to just above the pubis. The surgeon will then go in and examine all the abdominal organs to try to find a cause of the problem or any damage. They will then correct deficits or issues at that time. The surgeon will close the incision layer by layer, and then depending on the abdomen, they'll either use staples or skin adhesive to secure the incision site. Patients are often placed in an abdominal binder and will stay minimally 2 days in the hospital, usually longer, typically based on their plan of care. So if they have a colon resection, their prognosis might be different than if they had a liver resection, or if they maybe did an XLAP because the patient had a stab wound, but the knife luckily missed most of their abdominal organs, which has happened before. So kind of dependent on exactly what happened specifically for that patient will determine their prognosis. They will, however, be encouraged to walk and utilize their incentive spirometer after surgery. They will progress their diet slowly. Anytime you're working anywhere in the abdomen, you always want to be cautious of, not making the patient too sick at first. You don't want them vomiting or, not feeling well. And like I said, the postoperative care is widely dependent on other procedures performed. Complications for exploratory laparotomies can include excessive bleeding, infection, damage to internal organs, and even wound dehiscence. So that is where the abdominal contents will kind of herniate through the surgical incision. Another common procedure that we perform quite frequently is the colon resection. And so this is the surgical removal of all or part of the colon. It can be performed laparoscopic, open, or robotic. So we do an equal mix of laparoscopic and robotic colons. Open colon resections are a little less frequent, but we still do perform them. The official name is a colectomy, and we can have different versions of this procedure. So if you'll look over here on the right, there are different types of colon resections we can perform. So a right hemicolectomy, left hemicolectomy, a sigmoid colectomy, a subtotal or total colectomy, and a proctocolectomy. And so that area in white outlined in the dotted orange is the area that's being removed in each of those procedures. So indications for a colectomy would be if a patient has any sort of cancer in their colon, diverticulitis, especially if it's perforating their colon, ulcerative colitis or Crohn's disease, blockages or obstructions in the bowel, intestinal bleeding, and then again, abdominal trauma. So an incision is made depending on the approach. If they're doing laparoscopic, it would be very similar to a laparoscopic cholecystectomy where the surgeon is going in, placing the trocars, inflating the abdomen. If they're doing it open, they'll most often do that midline incision that they would do for an exploratory laparotomy. Either way, the surgeon will locate the area of problem or the diseased bowel that they are trying to work with. The blood supply and vessels to that area are ligated, and the diseased part of the colon is removed. That can be done through the use of those staplers that you saw at the beginning of this presentation. If possible, an anastomosis is performed. So if they take out a small portion of your colon and they are able to attach both ends back together, they do that. If the anastomosis is not possible because of either the state of the bowel or the amount of bowel that they had to remove, the patient might end up with a colostomy. After the colostomy is made, all the incisions are closed, dressings are placed, and the patient is sent to recovery. Patients often remain in the hospital for at least 1 to 2 days. It's highly dependent on the procedure. And then this is an area where they use a preoperative bundle known as ERAS, which is Enhanced Recovery After Surgery. And when a patient they call them an ERAS patient, they basically are optimized for surgical care. So they'll have high carbohydrate drinks before their procedure, they have a lot of education, they will minimize narcotic use, and these patients often do better and can go home earlier. We will talk more about ERAS later, so don't worry about it. Basically, all you need to know about ERAS is its surgical optimization of the patient preoperatively. They will also have VTE prophylaxis, so SCDs, foot pumps, TED hose, things like that. Patients will be encouraged to ambulate and advance their diet as tolerated. Monitoring for signs and symptoms of infection, and then if they do have a stoma, you'd want to make sure you're taking good care of that and providing education to the patient on how they can take care of it in the future. Complications from colon resections include bleeding, infection, damage to abdominal organs. Potentially they could have an anastomotic leak, so if the colon doesn't get joined back perfectly, a leak can occur. And then wound dehiscence through that abdominal incision. So those are the basics of general surgery here. If you have any questions, let me know, and I look forward to seeing you all in the upcoming week, and we will get you a really cool general surgery to watch. Have a good day.